Polypharmacy is one of the highest leverage problems in care of older adults, and we often don't talk about it enough because the average long-term care resident in Canada is on 8 to 12 concurrent prescriptions. And I know that sounds like a lot because it is. You know, we see their med list and we can see 8 to 12 different medications, and the cumulative anticholinergic burden alone is associated with falls, cognitive decline, and delirium. Not to mention, then you have the drug-to-drug interactions in this patient population, and that certainly isn't the exception. They're the rule. We're always looking at those drug-to-drug interactions, and especially even when starting cannabinoid medicine. And in our prospective study of medical cannabis in older adults, that was the one we did last year, the MCOP study, where we had close to 300 patients across 9 clinics. We did 6-month follow-up, baseline 2-month, 6-month intervals. We actually tracked the concurrent medication use as one of the secondary outcomes. And in a meaningful proportion of patients, we observed reductions in things like benzodiazepines, opioids, and antipsychotics. And a number of these medications are on the Beers list, which is basically like avoid in elder care. So I want to be careful, though, of course, as always, about how that reads. So cannabinoids in our practice in long-term care aren't a solution necessarily to polypharmacy. It's more of a tool that can sometimes create room to deprescribe. And again, when you're talking about behaviors of dementia, those antipsychotics are often what we're after. So when the right symptoms are being targeted, of course, when the framework supports it, and when there's clinical oversight, these formulations, cannabinoid-based medicines, can be useful. The bigger move is treating deprescribing as a clinical discipline in its own right, not an aftersight or an afterthought, not a once-a-year medication review, an active practice with protocols, evidence, and time allocation.